So this week we're going to talk about joints and the muscular system. There are four main structural classifications of joints. We have fibrous joints, cartilaginous joints, bony joints, and synovial joints. Functionally, we also can classify joints. This takes into account range of motion, or ROM. The three functional classifications of joints are synarthrosis, or synarthroses if it's plural. These are immovable joints. They can either be fibrous or cartilaginous. Amphiarthrosis, or amphiarthroses if plural. These are slightly movable. They can also be fibrous or cartilaginous. And diarthroses, which are freely movable, and these are also known as synovial joints. These are what we're going to focus on for the most part. So, like I just said, synovial joints are freely movable diarthroses. They have a joint capsule or articular capsule that covers the whole joint. The joint cavity will be filled with synovial fluid to prevent friction. The greater the range of motion, so the greater the angle of flexion or extension or abduction or adduction or rotation that a joint has, the weaker it is. So we want our larger joints especially to be more stable if possible, because if they are too flexible, we can end up injuring ourselves. So that's why we have all these accessory structures for stability, to make it so that our range of motion is a bit more limited, especially in our larger joints. There's also articular cartilage that covers articulating bones so that they can't touch. They have a slick, smooth surface, so any damage to the joint will damage the cartilage, which will allow friction between those bones, which could disrupt the periosteum and cause a lot of pain. Synovial fluid will function in lubricating the joint to prevent friction, distributing nutrients throughout the joint so that the cartilage can get its nutrients through diffusion, and it allows for some shock absorption as well. Accessory structures, like we said, are function to protect and stabilize joints. Some examples of accessory structures are cartilage and fat pads, ligaments, tendons, and bursae. So one example of a piece of cartilage that we find in some of our joints is called a meniscus. So a meniscus can help to subdivide the synovial cavity. It can channel the flow of synovial fluid, and it allows variation of shapes of articular surfaces. There are also fat pads, but these are typically superficial to the joint capsule, and they act as a sort of packing material to the joint. So all of these are normal accessory structures that occur within or external to joints. Ligaments connect bone to bone, so they are localized thickenings. They support, strengthen, and reinforce synovial joints. They can either be extracapsular, where they exist outside of the joint capsule, or intracapsular within the joint capsule. An injury to a ligament where it becomes a little overstretched is called a sprain. A tendon is not part of the joint itself, but typically tendons cross joints. It helps to limit the range of motion of the joint to provide a little bit more stability and mechanical support. An injury to a tendon where that's a little overstretched is called a strain. Bursae are small, thin, fluid-filled pockets that act as shock absorbers. They're found in areas of high traffic in our bodies, things that we often come in contact with the external environment in those places. So there are a couple of different types of bursae. We have synovial tendon sheaths. Those are tubular bursae that surround the tendons where they cross bones. And there's adventitious bursae, which develop in abnormal locations, usually due to some sort of mechanical stress. Some factors that stabilize synovial joints: the amount of collagen fibers, the shapes of the articulating surfaces and menisci, the presence of bone, skeletal muscles, and fat pads, and tension in tendons. Those all help to stabilize the synovial joints. So now we're going to talk about some actions of joints. Some joints have a gliding movement where opposing surfaces can move past one another in one plane. Some examples are your carpals, your tarsals, or your sternoclavicular joint where your sternum and clavicle articulate. Some other movements, flexion is when the joint between two bones, the articulation, those bones, the angle between those bones lessens so that they come closer together. Extension is when that is the opposite of flexion, so it's the increase in the angle between those bones. A adduction is bringing something closer to your body, like an arm, and abduction is bringing it further away from your body. Circumduction is rotating something in a full circle, versus internal rotation, which is rotating the joint medially, and external rotation is rotating the joint laterally. Supination and pronation, we typically talk about these when we're talking about your extremities. So if you were to supinate your hand, you would be putting your palm face up. And you can think about that as that's the way you would have to hold soup. You can't hold soup the opposite way. And pronation is the opposite of that when you flip your hand palm facing down. Some other special movements, inversion and eversion, we usually use when we're talking about the ankles. So inversion is rolling your foot so that the lateral surface of the foot is on the ground, but the medial surface is not. And eversion is the opposite, where the medial surface is on the ground, where the lateral surface is not. Plantar flexion is pointing the toes. Dorsiflexion is pointing the heel, so that's the opposite. Opposition and reposition are specifically referring to the thumb. So bringing the thumb and pinky finger together is opposition, and reposition is putting your thumb back into its normal place from opposition. Protraction and retraction you could do with your scapula. Protraction is bringing it forward, retraction is bringing it back. You can also do this with your jaw. Elevation and depression, you could do this with your shoulders. If you were to bring your shoulders towards your ears, you're elevating them. Depressing them is bringing them back to where they belong. And lateral flexion you could see with your neck. If you were to bring your ear to your shoulder, that's lateral flexion. Classifications of synovial joints, we have plane or gliding joints, hinge, condylar or ipsiloid, saddle, pivot, and ball and socket. We won't be talking about these specifically, but we may come up with some examples of these joints moving forward. One of the first main joints we're going to talk about are the intervertebral joints between your vertebrae in your back. These are fibrocartilaginous joints, and they're a mix of symphyses and synovial joints, so they're a little bit movable, but not that movable. The two main components of the intervertebral discs, which make up the joint, are the annulus fibrosus, which is the outer layer. It's a fibrous covering, and the nucleus pulposus, which sits in the middle, and it's kind of like a jelly filling to a donut. So if you were to put too much pressure on the disc, that jelly filling could come out of the intervertebral disc, and that would be a disc herniation. Protecting the disc on either side are vertebral end plates. And discs contain a lot of fluid, which is why they make a significant contribution to height. So this is why when you wake up in the morning, after a lot of fluid has moved into your discs overnight, when you wake up is when you are the tallest you are all day. And you're going to be a little bit shorter if you were to measure yourself at night. And this is also why with age you tend to shrink, because you lose disc height as your discs and joints get older. The main ligaments of the vertebrae is the ligamentum flavum, PLL, posterior longitudinal ligament, ALL, anterior longitudinal ligament, interspinous ligaments, and supraspinous ligaments. So these are the accessory structures that help to stabilize the joint. Our next joint we're going to talk about is the elbow joint. It is known as a hinge type of synovial joint. It involves three bones, the humerus, the radius, and the ulna. The olecranon of the ulna will prevent your elbow from hyperextending. The 3 ligaments that help to stabilize this joint are the radial collateral ligament, the ulnar collateral ligament, and the annular ligament of the radius. If the radial head becomes partially dislocated in childhood, that's called nursemaid's elbow. This is usually caused by a parent lifting their child up by the arm. One of the nerves that runs through this joint is the radial nerve, and the biceps brachii tendon crosses from your arm into your forearm over the elbow joint. The strength of the elbow joint comes from 3 different factors: the bony surfaces of the humerus and the ulna interlocking, the single joint capsule surrounding the humeral-ulnar and the proximal radial-ulnar joint, and the strong ligaments that help to reinforce the joint capsule. The next joint we're going to talk about is the knee. This is actually the largest joint in your body. You may think that the shoulder is larger, but the knee actually has way more components. That's what makes it a larger joint. This is also one of the most injured joints in the body. The knee joint helps to transfer weight of the body from the femur to the tibia. It contains 3 different articulations, so 3 different joints making up this one knee. The joint capsule of the knee tends to be thin and incomplete, which is why we need a lot of menisci and fat pads to help pack this joint to stabilize it. Some of the accessory structures of the knee include the quadriceps femoris tendon, which passes through the joint, the patellar ligament, 2 popliteal ligaments, and the anterior collateral ligament, the posterior collateral ligament, the medial collateral ligament, and the lateral collateral ligament. Next, we have the shoulder joint. It's also known as the glenohumeral joint. It's the most frequently dislocated joint in your entire body. It's known as a ball and socket type of synovial joint. And the surface area of the joint is increased by having a labrum. So the glenoid labrum within the shoulder helps to increase the surface area of the joint, and it permits an extensive range of motion. And this is why the shoulder joint is very frequently dislocated, because we have an extensive range of motion of the shoulder, therefore it can be injured much more easily. It's a weaker joint. Some of the accessory structures of the shoulder, we have the ligaments acromioclavicular, coracoclavicular, coracocromial, coracohumeral, and glenohumeral. So if you ever hear somebody talk about separating their shoulder, they're referring to the acromioclavicular joint being separated, a dislocation of that joint from the acromion process of the scapula and the clavicle. Another accessory set of structures that helps to stabilize the shoulder are the rotator cuff muscles, which are also known as the sits muscles. With these, we have the supraspinatus, the infraspinatus, teres minor, and subscapularis. So supraspinatus sits in that supraspinous fossa, infraspinatus sits in the infraspinous fossa, and subscapularis sits in the subscapular fossa. So that's why it's really important to know your parts of your bones. And teres minor is just lateral to all of that. Bursae are really common in the shoulder because it needs a lot of shock absorption and fluid, and this is also why there's a lot of incidences of bursitis in the shoulder. Next is the hip joint. The hip joint's another of your ball and socket joints. That's because the femur sits within a socket, which is the acetabulum. The hip has a labrum as well, called the acetabular labrum, which helps to increase the surface area of the joint. The ligaments included in the hip joint are the iliofemoral, pubofemoral, ischiofemoral, and ligamentum teres, which actually comes off of the tip of the head of the femur. Hip fractures usually occur at the neck of the femur, and hip fractures are much more common than hip dislocations because the hip is your strongest joint in your body. It has a pretty limited range of motion, but allows for great stability. When we talk about arthritis, there are 2 main types of arthritis. We have degenerative arthritis, or DJD, degenerative joint disease, also known as osteoarthritis. This is your most common type of arthritis, and when somebody says they have arthritis, likely they are talking about this type. It's a non-inflammatory type of arthritis, and it typically happens in an asymmetrical type of pattern where one side of your body will have arthritis before the other side, usually because you use that side more. So if you're right-handed, that'll probably be on your right side. This could also happen in somebody who has an injury. That part will degenerate faster. So if somebody injured their knee and that joint was damaged, then they would likely get arthritis in their knee on that side faster than the other side later in life. Rheumatoid arthritis is an entirely different type of condition. Rheumatoid arthritis is also known as RA, and it's an inflammatory type of arthritis. This causes disfiguration in joints. You'll generally see them being a little bit more bulbous than usual. It can also infiltrate tendons and cause a lot of issues there as well. Rheumatoid arthritis is considered an autoimmune disease. And this tends to be a little bit more symmetrical in its presentation, meaning both sides of your body tend to get it at once. Gouty arthritis is an infiltration of uric acid, and generally crystals deposit in your joint margin. This usually happens due to your diet. So if you eat a lot of aged cheeses and organ meats like liver and wine, you could get gouty arthritis at some point in your life. If you are immobilized for a period of time, for example, if you're wearing a cast or if you are recovering from a procedure and you're bedridden, this will lead to a degeneration of these joints, which can lead to arthritis long term. That's why continuous passive motion is so important, CPM, because it allows nutrients to get to your joints. There are some factors that contribute to the balance of bone formation and recycling, and those are age, physical stress, circulating hormone levels, the amount of calcium and phosphate absorption and secretion, and genetic or environmental factors. Hopping into the muscular system. So there are some common properties of muscle tissue. The fact that they are excitable, that they can be stimulated, they're contractible, they can shorten, they're extensible, they can elongate, and elasticity where they can return back to their regular size after they contract or extend. Skeletal muscles are really great at producing movement, maintaining posture and body position, supporting soft tissue, guarding your body's entrances and exits, maintaining body temperature, and storing your nutrients. Skeletal muscle attaches directly or indirectly to bones. All skeletal muscle is covered by epimysium. It can then be separated into fascicles or bundles via perimysium. So perimysium will cover the fascicles. Endomysium will cover individual muscle fibers. And muscle fibers are the cells of the muscular system. Skeletal muscle contains capillary networks, so there's a lot of oxygen exchange. Myosatellite cells, which are stem cells that help to repair damaged muscle tissue. And nerve fibers. They are highly innervated. Skeletal muscles attach to bones via tendons and aponeuroses, which are just a broader sheet-like type of tendon. Muscle contraction requires a lot of energy. They only contract upon stimulation from the nervous system, so each muscle has to be innervated, meaning that a specific nerve has to penetrate through the muscle belly and provide it with sensation so that it can contract. So the axons of that nerve would penetrate through the epimysium into the muscle belly. Skeletal muscle fibers are enormous. They're one of our bigger types of cells. They're also multinucleate, so they have multiple nuclei per cell. Myoblasts will fuse to form muscle fibers. Myoblasts are an embryonic type of cell. Muscles are striated in that they have a striped-like appearance. And they are composed of thick and thin filaments. Thick filaments are composed of the protein myosin, and thin filaments are composed of the protein actin. The arrangement of these filaments in their striated appearance is known as the sarcomere. So The different types of organelles within the muscle cell also have their own special names. The sarcolemma is the plasma membrane of the muscle cell, or the muscle fiber. The sarcoplasm is the cytoplasm of the muscle fiber. Any sudden change in the membrane potential, so remember when we talked about cells and how they have membrane potentials because there's always that slight negative charge of the cell membrane. Any sudden change in that negative charge can result in contraction of the muscle fibers, resulting in a contraction of the whole muscle. Transverse tubules, also known as T-tubules, are continuous with the sarcolemma, and they extend into the sarcoplasm, and their function is to propagate electrical impulses, also known as action potentials. The sarcoplasmic reticulum is another name for the endoplasmic reticulum, but only in the muscle cell. It forms a tubular network around each myofibril. Tubules of the sarcoplasmic reticulum enlarge and only on either side of the T-tubules. And this forms chambers known as terminal cisternae. When the terminal cisternae and T-tubules come together, they form a triad. The triad contains calsequestrin, which is specialized for the storage and release of calcium ions, so calcium can reversibly bind here. Branches of the T-tubule and sarcoplasmic reticulum encircle each myofibril. So each myofibril is going to consist of myofilaments. So we're just getting smaller and smaller into the muscle fiber. Actin and myosin are those proteins we talked about that make up thin and thick filaments. So contraction of these myofilaments leads to the whole cell contracting, the whole muscle fiber, which will pull on the tendon, contracting the whole muscle. So remember that the arrangement of these thick and thin filaments, the repeating functional units of these thick and thin filaments are known as sarcomeres. They're the smallest functional unit of muscle fibers, and they're composed of A bands and I bands. A bands are dark bands, and I bands are light bands. A bands are composed of overlapping thick and thin filaments. The M line is the center of the A band. The H band is the lighter region on either side of the M line. And then there's also a zone of overlap where thick and thin filaments overlap. In the I band, there are thin filaments but no thick filaments. This will extend from A band to A band, connecting them. Z lines will bisect the I band and mark boundaries between sarcomeres. I bands are also composed of titin, which is an elastic protein that extends from the tips of the thick filaments to the Z line. It kind of acts like an anchor. Thin filaments contain F-actin, nebulin, tropomyosin, and troponin. These are all proteins. Contraction occurs when the tropomyosin-troponin complex changes position. When it changes position, it exposes active sites. So tropomyosin prevents actin-myosin interaction. When troponin binds to it, it exposes active sites on the tropomyosin-troponin complex. And this change in position is caused by the influx of calcium ions. F-actin is also known as filamentous actin. It's composed of G-actin, which contains the active site where that myosin binds. And nebulin is another protein. It extends along F-actin between G-actin strands and helps to hold the F-actin strand together. So like we said before, the troponin-tropomyosin complex prevents myosin binding, and also tropomyosin helps to prevent actin and myosin interactions. Thick filaments have a core of titin, which recoils after stretching because titin is an elastic protein. And thick filaments, like we've said before, also contain myosin. So with the sliding filament theory, how does everything interact? What happens with the sarcomere? How does it function? So The H bands and the I bands narrow, the zone of overlaps widen, the Z lines move closer together, and the width of the A band remains constant. Another point that we should talk about during this is also the origin and insertion of muscles. Every muscle has an origin and an insertion, which is just the two ends of the muscle where they attach. The origin is usually fixed in position during contraction, so it's not moving, but the insertion point moves during contraction, usually toward the origin. Muscles contract due to action potentials. There are other types of potentials too, like graded potentials. These are a more localized form of action potentials, but action potentials are not graded potentials. Graded potentials only affect a small part of the plasma membrane, whereas action potentials affect the entire plasma membrane. When the resting membrane potential meets the threshold stimulus, depolarization can occur where sodium rushes into the cell. During repolarization, potassium channels open, making potassium run into the cell. Hyperpolarization is the very tip of this graph. There are some really good graphs for this in your book. And the refractory period occurs between action potentials or graded potentials, where another action potential or graded potential cannot occur until certain criteria are met. A neuromuscular junction is a synapse between a neuron and a muscular fiber. So a neuron in the nervous system is communicating with muscles. There are three components that make up the neuromuscular junction. That's the axon terminal of the neuron, the motor end plate, and the synaptic cleft between the neuron and the muscle fiber. Typically, what's exchanged here are neurotransmitters, and in the case of the neuromuscular junction, that neurotransmitter is usually acetylcholine. This link between an action potential within a neuron and muscle contraction is called excitation-contraction coupling. So the lock that's placed on the ability for the muscle to contract is called troponin, and calcium that allows those active sites to open is called the key. Once calcium influxes into the muscle fiber, contraction cycle can begin. The contraction cycle is a series of molecular events that enable the muscle to contract. This allows the formation of cross bridges. Cross bridges are formed when active sites are exposed and myosin heads can bind. So, why do muscles contract? Let's think about you lifting something. The tension that occurs within your muscles has to overcome the load of whatever you're carrying. So say you're lifting a weight. Your muscles have to overcome the load of that weight. So tension forces are a lot different than compression forces, as tension is willing the object's load to come toward the source of the tension, versus compression is pushing the load away from the source of the force. So in this way, we can think of it as muscles have tension rather than compression. So they can pull, but they cannot push. The greater the load that you're trying to pick up, the slower the cycling rate, which makes sense, right? Because it's more difficult and it takes a longer time for muscles to contract if you're lifting something that's heavier for you rather than lighter for you. There are three factors that come into play to determine how long muscle contractions last: the period of stimulation at the neuromuscular junction, the presence of free calcium ions in the cytosol, and the availability of ATP. So what happens when muscles start to relax, come out of this contraction phase? There is active calcium transport into the sarcoplasmic reticulum, and then there's also active calcium transport across the sarcolemma. calcium ions will detach from troponin. So remember, they're the key. Troponin is the lock. If they're detaching, the key's coming out of the lock. Troponin returns to its original position, and tropomyosin can cover the active sites of actin. But upon relaxation, sarcomeres will not automatically return to their original position. It will take a little bit of time. Some factors that influence tension is the fiber's resting length at the time of stimulation and also the frequency of stimulation. The length-tension relationship will depend on the number of power strokes. It's most efficient within an optimal range of lengths, the amount of tension that you have in your muscles. At the optimal range of lengths of the muscle, maximum number of cross bridges can form and maximum amount of tension can be produced. However, no tension can be produced when the resting sarcomere is at its shortest length. Twitches occur when one muscle fiber goes through the stimulus contraction relaxation cycle. Just one. If it's a combination of a collection of muscle fibers, but not all of your muscle fibers, that's known as a fasciculation. Twitches go through 3 phases: the latent period, the contraction phase, and the relaxation phase. Another variation of muscle contractions is known as Treppe. It's German for staircase. This does not occur in most muscles, most skeletal muscles, but it does occur in cardiac muscle. Wave summation is a summation of twitches, so a lot of twitches happening. So if you're getting a lot of stimulus, if you're getting more than 50 stimuli to that muscle fiber per second, that will cause a wave summation. Next, we have incomplete tetanus. So the muscle produces almost all of its tension, its maximal tension, during rapid cycles of contraction and relaxation, but it's not its completely maximal tension yet. There's still a period of relaxation. So think of this almost like a spasm. Complete tetanus, also known as tetany, is the complete elimination of the relaxation phase. There's a high calcium concentration leading to continuous contraction. No relaxation, the muscle is just continuously contracted. So this happens in the disease tetanus. We also have different types of contractions. We have isotonic and isometric, and we have different types of isotonic contractions known as concentric and eccentric. In isotonic, we have the muscle is going to be changing length due to the load that's placed on it. Isometric, there's no change in length. So, as I just said, in isotonic contractions, tension increases and the length of the muscle changes. So with concentric contractions, the muscle tension exceeds the load, so the muscle shortens. So think of this like doing a curl. Your biceps will undergo concentric contractions as you're lifting that weight. That muscle belly will shorten as it contracts. With eccentric contractions, the peak tension is less than the load and the muscle elongates. The muscle cannot overcome the load of the weight. So think of this as relaxing the biceps and bringing the weight back down. So during weight training, typically you do repetitive concentric and eccentric contractions. In isometric contractions, this is when tension is produced but does not exceed the loads and the muscle does not change length. Think of this as just simply flexing. You can hold your muscle like that, but there's not really a load to overcome. Motor units are known as a motor neuron and all the muscle fibers it controls. So smaller motor units tend to control more intricate muscles, more intricate movements. Larger motor units control more gross movements. Larger movements. Recruitment is when smaller motor units activate larger motor units and causes a smooth but steady increase in muscle tension. At this point, we also have asynchronous motor unit summation, where During recruitment, you have multiple motor units that are activated, but they don't all activate at once, so that they can't all fatigue at the same time. Muscle tone is the resting tension that's in your skeletal muscles. This is what makes people look muscular. It stabilizes the position of your bones and joints. And it also increases your resting rate of metabolism. So the more muscle tone you have, the higher your metabolism is. Hypertrophy of muscle occurs especially when you work out or you're taking in a lot of protein after workouts so that you can build more muscle. So the muscle getting larger is known as hypertrophy. The muscle kind of deteriorating is known as atrophy, and this can happen for a wide range of reasons. It could be that you're not using the muscles, it could be that they lost their innervation, it could be that they're immobilized for long periods of time, or it could be genetic. So the load and speed of contraction are inversely related, which makes sense because, like I said before, the heavier something is, the longer it takes for contraction to begin. And you can see this with biking when you put your bike to different speeds and different resistances. So relaxation occurs with the use of elastic forces. It can also occur due to opposing muscle contractions. So opposing muscles are muscles that do opposite actions over the same joint. So think of the biceps and triceps. They are opposing muscles because the biceps flexes the elbow and the triceps extend the elbow. So if the biceps were to flex, it forces the triceps to relax. Gravity also causes relaxation to occur because after time your muscles will succumb to gravity. Normal muscle function relies on substantial intracellular energy reserves, normal circulatory supply, normal blood oxygen levels, and a normal blood pH. Muscle metabolism is the sum of physical and chemical changes within a muscle. And of course, muscles use ATP in order to function. Actively contracting muscle fibers breaks down 2,500 ATP molecules every second. So it is definitely not good for your energy reserves to constantly be contracting your muscles. Your body only contains enough ATP to sustain an initial contraction, so you need to constantly be making ATP as you exercise. Which is why some people feel like they feel really energized after they exercise because they're making ATP during that process. The difference between force and endurance. So endurance is how long you can sustain using your muscles, while force is more about using your strength for short periods of time. There are 3 different types of skeletal muscle fibers that help us with force and endurance training: fast fibers, slow fibers, and intermediate fibers. Fast fibers are most of our skeletal muscle fibers. They produce the most powerful contractions, but they fatigue pretty rapidly, so this is good for strength training. Whereas slow fibers are better for endurance training. They take 3 times as long to reach peak stimulation, but they fatigue less quickly. And they're surrounded by an extensive capillary network containing myoglobin for oxygen storage, so they hold extensive oxygen reserves. Myoglobin is also what gives muscle its color, which is why it looks more red. And intermediate fibers lie somewhere in between, so they're less able to fatigue than fast fibers. As we age, muscle fibers will become smaller in diameter. They'll also become less elastic, and your tolerance for exercise will decrease, and your ability to recover from injury will also decrease. Muscle fatigue occurs when there's a depletion of the metabolic reserves within a muscle fiber, damage to sarcolemma and sarcoplasmic reticulum, a decline in the pH within muscle fibers and decreased calcium, and a sense of weariness and reduction in desire to continue activity. So at this point during exercise, when you completely fatigue your muscles, they're is literally no more energy that you could possibly put into doing more exercise. You might feel kind of like a jello type movement in your muscles at this point. This is typically a cumulative effect, and it will reduce your capabilities and performance. So that was all skeletal muscle. Let's talk a little bit about cardiac muscle. Cardiac muscle is an excitable membrane. It has branched muscle cells. And going back to the excitability of this membrane, it also has automaticity, meaning that the muscle contraction can occur without neural stimulation. Cardiac muscle is dependent on aerobic respiration, and it also contains intercalated discs which help to communicate with other cardiac muscle cells in order to propagate these electrical impulses within the heart to keep it beating. The functional characteristics of cardiac muscle, it's known as a functional syncytium. We already talked about that automaticity, and the pace of the heart contractions the pace is made by the pacemaker cells. Contractions last 10 times longer than skeletal muscles, and tetany and wave summation cannot occur in cardiac muscle. Smooth muscle coordinates movements of materials throughout internal passageways. It's found in the integumentary system, the cardiovascular system as the walls of arteries and veins, respiratory system, digestive system, urinary and reproductive systems, and all of those organs. Smooth muscle also contains actin and myosin. It's considered a non-striated muscle, which is why it's called smooth. Its thin filaments are attached to structures called dense bodies, and these never form tendons or aponeuroses. The trigger for contraction within smooth muscle is the appearance of free calcium ions. They interact with calmodulin, which is a calcium-binding protein, and this activates myosin light chain kinase, which enables myosin to attach to actin. Tension development and resting length aren't related in smooth muscle, and this is because stretched muscles can adapt to their new length, and that's called plasticity. So they can continue to contract even when they're at a stretched length for them. They also lack sarcomeres and can undergo sustained contractions. Multi-unit smooth muscle relies on motor units, while visceral does not. The tone of smooth muscle is influenced by neural, hormonal, and chemical factors, and it relaxes in conditions of depleted oxygen. So now we're going back into skeletal muscles a little bit. We're going to talk about the different shapes of skeletal muscles, and we're going to go through the different named skeletal muscles that are really important in our bodies. So the muscle shapes. There's a pennate shape, a parallel shape, a convergent shape, and a circular shape, also known as a sphincter. Bones can act as levers for muscles. So levers move on fixed points called fulcrums, and they move when an applied force is sufficient to overcome a load. A mechanical advantage is when the force is farther from the fulcrum than the load, and a mechanical disadvantage is when a force is closer to the fulcrum than the load. There are also first, second, and third class levers, but I don't care that you know what those are. Levers can change the direction of the applied force, the distance and speed of the movement produced by the force, and the effective strength of the force. We've already talked about origin and insertions, but just know that most muscles originate at bones. Muscles can also have different actions. The agonist is the prime mover, so for a specific movement, such as flexion of the elbow, the agonist would be the biceps, as they are the primary mover in flexing the elbow. The antagonist would be the muscle working against this muscle. For example, in this case, it would be the triceps, because it acts to extend the elbow, so it's acting as an opposing force. A synergist will help the agonist to do its job, but it's not the primary mover. So a deeper muscle known as the brachialis might help the biceps brachii to flex the elbow. And fixators are there to help stabilize a joint. There are between 600 and 800 muscles depending on who you ask. And oftentimes they are descriptive of what they do or where they are. For example, externus or superficialis means that that muscle is an external muscle or superficial muscle. Internus or profundus means that it's internal. Extrinsic also means external. Intrinsic means internal. Transverse means it crosses the transverse plane, and oblique means that it runs at an oblique angle. Rectus means straight. Longus or longissimus means that it's a long muscle. Brevis means that it's short. Magnus major or maximus means that it's large, and minor or minimus means that it's small. They can also, like I said, describe the action that they do. So some of them start with flexor, extensor, pronator, adductor, abductor, or rotator. Most of the muscles in your body are found in your axial skeleton. There's about 60% of them there, and 40% are within your appendicular skeleton. And all muscles are innervated, like we've talked about before, where they need an axon to penetrate the epimysium of the muscle belly in order for them to actually be able to contract. So let's talk about some of these really important muscles. Some of the circular muscles in your face are your orbicularis oculi, which surround your eyes, and the orbicularis oris that surrounds your mouth. This helps to pucker your lips. You also have these really long muscles that go from your jawline down toward your clavicle, known as your platysma, and it helps to make a really cringed face. You have muscles of mastication, known as your buccinator, your masseter, and some deeper ones that aren't pictured here. These are your extrinsic eye muscles. You have superior oblique, superior rectus, lateral rectus, medial rectus, inferior oblique, and inferior rectus, all surrounding your eye and attaching to the back wall of the orbit. They surround the optic nerve, where it inserts into the skull and into the brain to be able to transmit visual stimuli to the occipital lobe. So we'll talk about the cranial nerves in a couple of weeks when we're going through the nervous system. Okay, so here are your muscles of mastication. We already talked about masseter. We also have temporalis, which is a pretty large muscle sitting on the temporal bone. Internally, a little bit more deep, we have the lateral pterygoid and the medial pterygoid. Usually when you have jaw pain, it's because of these muscles. These are deep muscles that get a little spasm in them sometimes, especially with stress. You have some muscles that help to move the tongue. You have paladoglossus, styloglossus, genioglossus, and hyoglossus. Muscles of the pharynx. These are pretty deep. You have tensor veli palatini and levator veli palatini. And of the anterior neck, these are found underneath the mandible. Notice that most of them are named with hyoid in the name, and that's because they're all attaching to hyoid, keeping this bone in place since it doesn't articulate with any other bones. These are your muscles of your back. They're all considered erector spinae because they're your postural muscles. They help keep you erect or straight. The main ones are iliocostalis, longissimus, and spinalis. Your abdominal muscles, you have your obliques, your internal and external obliques. You have your rectus abdominis, which has these planes of fascia in between that give you your six-pack. There's also muscles of the pelvic floor. This is an example of a female, but these are found in both males and females. There are muscles of your pectoral girdle, so your trapezius, a lot of people think it's only in the shoulders, but it actually inserts all the way down into your lower thoracic spine, your T12, and all the way up into your skull, and it comes out all the way into your shoulder. So it's a very broad muscle. It functions in helping to keep your arm attached to your body, so that's pretty important. We have your levator scapulae, which tends to give a lot of pain to people who are stressed out. It connects your scapula to your neck. You have your rhomboids that are really important for your posture. They help keep your shoulders back and not rolling forward. So if your shoulders are rolling forward, it's a good indication you should try to strengthen these muscles. Your serratus anterior is a little bit deep to your rhomboid muscles. It covers your ribs and the posterior thoracic cage. And we can see a little bit of the posterior arm here where you find the triceps brachii, which you can see branches off into two different heads. On the anterior view, you can see that trapezius still coming up into the skull, levator still going up into the cervical spine, pectoralis minor, one of your chest muscles, and then we can see biceps brachii in the anterior side of the arm here, and it also breaks up into two heads. Here's a more superficial version of that last slide. So we have pectoralis major going over pectoralis minor, which would be deep to this. The deltoid being one of your main shoulder muscles, forming the curve of the shoulder. Deep to all of this on the underside of the scapula, you have subscapularis. Going to the posterior view, you can see supraspinatus in the supraspinous fossa, infraspinatus in the infraspinous fossa, teres minor, which are all rotator cuff muscles, and subscap being on the other side being our fourth rotator cuff muscle. We can also see latissimus dorsi here. It's one of our biggest muscles of our back. It comes up and inserts into the head of the humerus. And we have some more muscles of the arm. So you can see the triceps again. This is the posterior view. The brachioradialis, the anconeus, which is this cute little triangle muscle on your elbow. All of your extensor muscles will be on the posterior side of your forearm, which is really important to note. Your extensor retinaculum is a piece of fascia that covers the posterior side of your wrist. Then we have from the anterior view, you can see the biceps. You can see brachialis a little deeper to that. You can see brachioradialis. And it's also important to know that all the flexor muscles of the forearm are on the anterior side of the forearm. That would be good to know too. So this is another view of those. You've got these little tiny deep muscles called lumbricals in your fingers. It's a lot of muscles here. Any of them that refer to the thumb will say pollicis in them. And when they're referring to the pinky, they will have digiti minimi in them, like minimal digit, tiny digit. In the thigh, there are three gluteal muscles. You have the gluteus minimus, which is really deep, gluteus maximus, which is, as it sounds, very large, and gluteus medius, which helps protect the hip and keep it level. We also have the IT band here connecting the tensor fascia latae, or the TFL, and anterior to the IT band are all the quadriceps, posterior are all of the hamstrings. So here's a deeper view of those gluteal muscles and some extra ones. One of the most important ones of your body is your largest hip flexor, known as the psoas. It's one of your deeper abdominal muscles. Your adductors are your pectineus and gracilis, and some of the named adductors. Here we have your hamstrings, semitendinosus, semimembranosus, and biceps femoris. And the quadriceps being the rectus femoris, the vastus lateralis, and vastus medialis. Sartorius is also in there, crossing from the hip to the knee. In the calf, we have the soleus, which is deep to the bigger muscle known as gastrocnemius. Notice that they come together to contribute to the Achilles tendon, also known as the calcaneal tendon. Deeper to that, we have tibialis posterior and fibularis longus and brevis, also known as peroneal longus and brevis. And here's a deeper picture of that. And for the big toe, if there's any muscles that relate to that, it'll have hallucis in the name rather than pollicis for the thumb. And notice that the toes also have lumbricals, just like the fingers do. During exercise, the cardiovascular system will dilate blood vessels and increase the heart rate to bring oxygen to tissues to allow more oxygen into muscles. The respiratory system will increase the respiratory rate to bring more oxygen into your system. The integumentary system will increase your amount of sweat gland production so that you're able to reduce the amount of heat going on in your body. And your nervous and endocrine systems will coordinate all of the above processes.